Let's switch our gears to KEYNOTE-811, which indeed is in fact a standard of care option for HER2-positive GEJ and gastric adenocarcinoma patients. Kristen, can you please walk us through the study design and important takeaways here?
Sure. So KEYNOTE-811, we've been watching for a while now. This is a study that enrolled patients with advanced or unresectable gastric or GEJ adenocarcinoma who had been previously untreated. As you mentioned, they were HER2 positive, so they had to be IHC3 plus or IHC2 plus FISH positive. And so patients were randomized in this study in a one-to-one fashion to pembrolizumab plus trastuzumab plus chemotherapy. So either 5-FU cisplatin or CAPOX, with the majority of patients receiving CAPOX, versus trastuzumab plus chemotherapy plus placebo. And patients were treated until toxicity or progression, or a maximum of 35 cycles of treatment. So we had originally seen in the early interim analyses, we had seen really impressive response rates with the pembrolizumab arm, and this actually led to accelerated approval in this this patient population. So over time, as we've seen more of the data roll out and some of the longer term information, what we saw here was the overall survival analysis in the intent to treat population. And what we saw was that the median overall survival was in fact better in the pembrolizumab arm versus placebo. Now, what has been a little bit controversial in this study was really the data behind the subgroups according to PD-L1 and PD-1 status. So it did look like the patients benefited more the higher the PD-L1 score was, which makes sense, as we might imagine, but it did show an improvement in all comers.
Kristen, this OS certainly reinforces our current practice, but taking a little deeper dive into the subgroup analyses. In your clinical practice, a patient that is PD-L1 negative, because as you've stated, PD-L1 and above, we saw more benefit with pembrolizumab. So PD-L1 negative patient, would you add pembrolizumab or consider just chemo and trastuzumab?
Yeah, I in the PD-L1 negative patients, both HER2 positive and HER2 negative, I do not give PD-1 inhibition to those patients, because you do have to think about the toxicity. We traditionally think immunotherapy is reasonably non-toxic, but it can have significant adverse events that can be irreversible. So I think it's important to maximize the safety and the benefit there. So I don't give patients who are PD-L1 negative this particular treatment. But, you know, in this study, actually 85% of patients were PD-L1 positive. So it does go to show that most patients will be eligible for this treatment.
Absolutely. When talking about these biomarkers, another biomarker, and we saw an update here at ESMO 2024, was also with Claudin 18.2. Zolbetuximab showed overall survival. We're waiting FDA approval on that. And then we also saw TDXD is showing activity in HER2 positive space. As a general community oncologist, that's not surprising, because we've seen that in lung cancer, breast cancer, of course. So we'll wait on these studies and see how this space continues to change.